Well, hello, and thank you for having us again. I am Corinna Brower. I use she, her pronouns, and I'm the state school nurse consultant. So I'm housed in the public health division in Oregon Health Authority. And I'm presenting with Eli.
Good afternoon, Eli Sanders. I'm the School Health Services Specialist with the Oregon Department of Education.
And today we are following up from 2 weeks ago, talking about emergency planning. And today we're actually going to start with a recap very briefly of some of what we talked about last time. We're going to focus really on holistic planning. So both individualized and large scale, thinking about the whole picture, and then spend most of our time talking about scenarios. So we've pulled some real life scenarios. We're going to talk about applying that holistic planning idea to those scenarios. So we're going to jump right in. To recap, last time we talked about regulations. And in very brief, there are laws in Oregon that refer to the requirements for school nursing services. There's what we call the ratios law, and then there's law that refers to ensuring availability of a nurse. We also have laws that address required school health services, particularly focusing on the fact that there needs to be a prevention-oriented health services plan that includes communicable disease, mitigation and planning, services for all students, and emergency response planning, inclusive of medical emergencies. We also talked about some of the local priorities, so bringing it down to the local level. We talked about the fact that where we are right now today, the school safety and emergency management team has a number of resources. We talked about resources for individual planning with nursing and student plans, so Oregon School Nurses Association and American Academy of Pediatrics particularly. And then we spent a little time focusing on teams and systems and really emphasizing that all of this, one of the biggest pieces is collaboration and communication. And, it's never a one person. And focused on specifically some of the nurse role examples and integration of the school nurse into some of this planning. And today, as I mentioned, we're really focusing on the intersection of individual conditions and emergency events. So whatever the emergency, if we have some sort of school-wide or multiple people event, planning ahead and taking into consideration students that may have different mobility challenges, vision and hearing impairment, individuals with intellectual disabilities or neurodivergence, all of those sorts of things are constantly on our mind as we're doing emergency planning. And one of the ways we do that is looking at, this is one of the resources that we highlighted last time, setting up a personal emergency accommodation plan, or a PEEP. And this form specifically is looking at, in the event of some sort of evacuation, what are some of the supports an individual student might need. We talked about how this might be sort of connected with our overall emergency plan and protocol. It may also be connected directly with the student's individualized healthcare plan and emergency action plans. Just making sure that we've taken into consideration what those specialized needs are going to be. And we also are going to touch briefly on the idea of targeted universalism. This is something that has been talked about in a number of circles the last few years, with the idea being that whether or not we know of a student's specific health condition or mental health needs, we're intentionally using interventions that address specific needs that we can anticipate to improve outcomes for all. So, for example, even if we don't know that a student has specific anxiety disorder or impaired immune system, if people haven't disclosed all of those things, we may still be able to put planning into place that's going to be protective and enhance the safety of all students. So we're going to move into scenarios discussion, and I'm going to hand it over to Eli to introduce us to this section.
Thank you, Corinna. And please feel free to pop any questions in the chat, or come on off mute or on video and let us know. Happy to kind of break it up a little bit with discussion. So the next, we have 4 scenarios that we're going to be discussing. Each scenario is divided by a page of pretty wildflowers or other things, but knowing that some of these scenarios may may be triggering, may create emotional response. And so just acknowledging that emergencies have impact, not only just during the emergency, but oftentimes long after. And we'll discuss that a bit. All these scenarios are ones that Corinne and I have worked with school districts around um, and have been involved in, and we've done everything we can to remove any kind of identifying detail related to certainly the students, but also school districts and whatnot. The four scenarios we're going to look at. First one is a scenario, first emergency scenario is an acute injury of a student. In this case, head injury. Second one, health condition. This one is took place in a rural school district, around 4,000 students with one RN in relationship to a seizure, a student who experiences seizures. Third one, communicable disease. This has happened at an outdoor school with roughly around 600 students with a nurse on site. And then finally, and we hope to get to all four. We're going to look at an external threat where there's a lockdown in a suburban school district, roughly 10,000 students, where there's 3 RNs. So this first scenario, head bump, head injury. This just to be transparent, and I'll I'll de-identify this situation because it was my daughter who was 6 years old, a kindergartner student, and so the school has the required 1:60 ratio of staff trained in first aid and CPR. The after-school sports coach, as well as maybe some others, are trained in relationship to Max's Law for concussion management. And there's a protocol in place for head bumps or head injuries that occur at school. There's a registered nurse. The school nurse, however, is assigned to the school but not present at the school. The school nurse serves 3 other schools and has a health assistant that is on site at all times. So in this case, my daughter, Sophia, she fell on the playground unwitnessed. She was found unconscious by a playmate. The student woke up. The playground monitor sent the student to the front office and unescorted. The school RN was not on campus and was not called or notified during the event. The front office staff provided a student with ice pack. The student was sent back to class. Student told the teacher that she couldn't see. Mother picked her up. Student was drowsy, started vomiting. Ultimately was transported via the ambulance to the hospital for assessment after 2 hours. Student received hospital care and was diagnosed with a concussion. After clarifying details with staff and parent, the nurse assisted with developing a short-term accommodations plan and provided training to applicable staff. So each of these scenarios, we're going to look at like some of the positives and some of the maybe problem areas or areas for work. So in this case, there was a protocol that existed. So there had been discussion and some training provided. After the diagnosis, the staff support implementing accommodations and worked with us quite closely as far as making sure the student felt safe and received the accommodations required. Just a side note, there's legislation currently being proposed this session related to this exact scenario around accommodations for concussions. Some of the challenging areas was that the protocol was not followed, primarily because the nurse was not consulted. And as a result, the care was delayed for 2 hours. The student in this situation of a head injury, the thing that we fear most is a potential brain bleed that can have serious consequences. So as we think of this scenario and planning for an acute injury like this, and similarly, it could be a fracture on the playground, laceration, something like that. In this case, a head injury. What are a couple of proactive planning changes that could improve the future outcome in this scenario? Number 2, imagine an acute head injury occurred in a student who is nonverbal. So we're looking at maybe a student who experiences a disability. What is a plan or protocol example to ensure that the student is safe? So what I would like you to do is certainly, I think we prefer conversation or discussion, if people want to come off mute, or if you have comments, take a second and you can put them in the chat and we can discuss further. Do you have any ideas? I imagine what we know is head injuries happen quite often, and they can run the continuum of being very serious or or a bruise or a goose egg. What's your experience at the district level as far as how head injuries are treated? And I invite my ODE colleagues too if they have comments or.
I'm going to ask this, if people want to be slightly more anonymous, if you wanted to put in the chat, do you know for certain if there is in your setting a protocol, a standard response, a standard form that's used, that sort of thing? If you have some head bump protocol that's in place.
We see one in the chat saying, ensure lunch aides are trained in CPR or concussion protocol. The potential planning change.
One of the things that we discussed with this school district and further on, and with other school nurses from around the state is that concussion protocols are really, I was gonna say hit or miss. That might be too much on the nose. But that not all districts have specific protocols for when there is a potential or a head injury suspected. So on the plus side, this district had a very comprehensive protocol that was understood at the school nurse level. But yeah, certainly the training comes in as a big component, and I would imagine I'm looking at our team, ODE team, like that training becomes such a key variable is how often, who is trained, how do we ensure that from year to year that people are retaining that information and able to respond to an emergency.
And that's a piece that's going to come into play in these other scenarios as well. Is it's great if there's a protocol, it's great if there's someone, the nurse or the health aide or someone that knows it, but if we don't have a little bit more universal, at least people know who to call if something happens, right? Then we end up with gaps.
And
So
Bianca,
that, go ahead, sorry.
Bianca asked, how often are school nurses off campus? I would maybe rephrase it. How often do school nurses get to be on campus? Primarily because we have a significant shortage in school nurses across the state. So vast majority of the time, a school nurse does not get to be assigned to a single school building. They're more assigned to a district.
Based on our last 2 years of surveys, 21 and 23, between 10 and 15% of nurses are assigned a single school, but 15 to 20% are assigned 6 or more. And the average for a full-time registered nurse is to serve 4 schools right now. I will also say 10 years ago, we had about 200 FTE of registered nurses in schools. And as of the most recent data, we have over 400. So it is improving, and we hope it continues improving. But as part of emergency planning, being aware of in your district, how often is the nurse physically present versus are they on call versus are they part-time and not even going to be available on call? So just incorporating that into your emergency planning, I think, is pretty key.
Can I ask a question for schools that have no school nurse? In our district, we're a small district of Willamina, and we just, I mean, I've been here 12 years, and in my 12 years, we have not had
So
one.
the question, sorry, Brent, I'm wondering the question.
I guess it's, would the protocol just be, and I mean, you don't have to write the protocol for us, but like just 911, I mean, is that appropriate? There's a head injury, call the parent. If the parent wants you to call 911, that's it. When we don't have really anybody on staff that is trained. I mean, we have CPR, we have first aid, but that would feel comfortable either diagnosing a concussion or even I never say the word if a kid hits their head and I'm calling home for it, I don't say it. I just say potentially. Is that enough if you just don't have a nurse that serves your district?
I'm going to be just a titch tongue in cheek and say, if you don't have a school nurse, the best protocol is to get a school nurse. And I know reality wise, we have quite a number of districts. I mean, there's districts that have fewer than 100 students total, that kind of thing. There are places that consult or contract for a limited number of hours, or have a nurse come in and work with the school and the staff and develop some of those protocols, so they're familiar with the individual school setting. We're working very much at state level and regional level to try and develop additional support, so that, for example, there are some places where the ESD hires nurses and contracts them out, and that often makes it more possible for some of our smaller districts to access nursing services, if you're not in position to employ someone full-time, but you can still have access. So that is not directly addressing your question, but that's the direction that I would go in terms of making sure that things are safe and medically appropriate and evidence-based, is to bring in that expertise somehow, even if it's, just a week at the beginning of the school year or something, that you've contracted someone to come in, ideally someone who has that school nursing experience and has worked with other communities doing this similar thing.
No, that's great. Thank you.
And I would add, one of the things, and for this district, we want to get away. We don't want to get into doing a nursing assessment of a student with a health condition, but there's some, and this is some of the resources that we're looking at developing at the state level. As I mentioned, there's legislation that's being proposed right now. Session goes through June, so we're kind of in the middle of. We don't want to build something while something is also being proposed at the legislature, but what's in place in this school district, because a school nurse isn't on site, is that decision tree for unlicensed staff member to kind of follow in order to call nurse, call 911, call parents. And so depending on what they're seeing, or what they know. And so there may be something like that your school district could implement, as far as, if the student says they fell, there's no signs, symptoms, you don't want to call 911 necessarily for a minor scratch. But at the same time, if there's these things present, what to do. So there's a process in place.
We do have it for follow-up if we want to send some emails. There are a number of districts that have exactly that type of flowchart or rubric in place, and there are also some out-of-state examples that are similar, that will have 50 or more conditions where there's that sort of rubric that could be adapted for your school setting. And again, I would encourage having someone with both expertise on your school setting and some of the medical expertise to be able to fine-tune what that rubric looks like for your setting, if that's the way you end up going.
That'd be great. Yeah, thank you.
And then last, I would say, in alignment with the OAR changes that happened in 2023, with our health services rule, that districts must ensure access to a school nurse in relationship to students with medical diagnoses. It may be, as far as working with folks who are filling out that prevention or health services plan, is seeing if there's a place in there, as far as the plan to ensure access when needed for to a nurse when needed, in relationship to a student showing up with diabetes or with a seizure condition or something like that. Can that same relationship or availability of nurse that's established in the plan that's reported to ODE, can that same position be available to consult on some of these protocols, that because there's not a nurse, it'd be really helpful to have processes in place to know, for staff to know when to call 911 or parent or those kind of things. It builds the tool chest of the non-licensed staff in the absence of the nurse.
And that's exactly what the second question is pointing towards, is if we have a student who has, in this example, is nonverbal, maybe a student with intellectual disabilities, someone who's potentially presenting differently and might not be able to communicate as clearly what's going on with them in terms of symptoms, having some of that in place, either being able to call the registered nurse in for a more thorough assessment, or having some of those other plans in place so that it's, using the rubric example, if loss of consciousness, call 911, if vomiting, call 911 kind of thing. And someone who knows the student, who has done some sort of pre-assessment, knows their baseline and is able to assess them more specifically. So that kind of thinking ahead of, in general, we're going to do this for a head bump, we're going to ask the kids such and such, but if we've got different situations, being ready to respond to all kids and all communication abilities. All right. Thank you for that. We're going to take
The forest.
our lovely Forrest. Our next scenario is going to talk about a 911 call. So just recognizing that that's something a lot of us have experienced over the course of our careers and can be quite activating to think about. In this case, it resolved well. So background for this one, we asked for some of our colleagues to share stories. So this was submitted by a current school nurse. We have an elementary student with a history of seizures. The nurse and the parent have developed the emergency action plan. Nurse has provided training to multiple staff members, including how to recognize and respond. And then in the event, they recognized the student was showing signs of impending seizure. The student was escorted to the office. Parent was called. After the parent arrived, just as they were leaving, the child fell to the ground and started seizing, basically in the doorway. And the health aide helped move the child back into the school. They put the mom's jacket on the floor. The health aide went and grabbed the emergency medication. The parent administered the dose. And then they called 911 and EMS arrived very quickly. This was our rural district. And then in this particular case, the student was given multiple doses on site and couldn't get the seizures to stop. So they were transferred to the hospital. They received care. Their orders were updated, and the nurse has worked with the parent and retrained staff for those updated orders. And so positive aspects, this person who submitted this said, I was really impressed at the calmness of most staff, especially the health aide. They did what they knew to do and maintained, just followed their protocols. The problem area was that not all staff were calm, and no one assisted the health aide, and no one secured the area or helped to redirect students or staff. So again, kind of a situation where we've got some people that know exactly what to do and know the protocols, but kind of lack of that fully coordinated approach. So this one, we have questions similarly. Is there a change that could improve future outcomes? And then adding that, let's just layer the mitigation planning. If this particular student had a seizure, or any other student had some sort of significant medical event during a fire drill, we're not in our usual place. We're not, maybe we can't access the front office or whatever it is. What's the plan or protocol to ensure the safety of students that have emergency medication? So again, opening it up, if anybody wants to share, if this is a familiar situation, if there are certain plans and protocols that you have in place that have helped.
I'm going to jump into the conversation first and say, this is one of those situations where it's great to have that hold drill and practice that ahead of time. As soon as this happens, that's when you want to enact that hold to keep that area clear. Just like you had in that previous slide, we were talking about things that could have been done a little bit better with respect to clearing the area and making sure that area was safe for the response. But I always like questions like this too. What happens if something like this happens during a fire drill or even a real fire response, right? You're actually evacuating the building. That adds additional challenges that a hold drill is not going to be able to fix, especially trying to get everybody out to a safe area.
One of the things that comes up for us often is the idea of having some sort of a go bag, or anytime there's a fire drill, anytime there's an actual event, the life and death, life-saving treatment protocol medications are either in an easy storage space, the bin can be grabbed, or they're they're always kept in a bag so the person can grab it and either run to the student who's having the emergency or take it with them when there's a fire drill. So it's not, off limits, locked up in a space where they can't get back to it. And in all of these, I want to emphasize too, there was clearly planning that was in place that made these events a lot more positive outcomes than they could have potentially been. So a lot of positive there. But again, just trying to make sure that we're layering that with every single event. All right. Thank you for that one. We're going to move on to, I'm sorry, this is the nurse in me, but the next one is kind of my favorite example because it's just so intense. So little breath, this is focusing on communicable disease.
So this happened a while ago and was brought to my attention probably 6 or 7 years ago. And I was touring an outdoor school and just learning kind of the life, spending a day in the life of a school nurse in an outdoor school. And they're like, God, you would have no idea. You have no idea what happened last year. And so what happened was this outdoor school serves 500, 600 students at a time, primarily in grade 6. And they come from multiple districts. There's a full-time nurse on site to provide medication administration, to respond to injuries or acute illness. And the setting is rural, wooded, pitted toilets, has running water, but kind of 2 primary stations, showers and sinks for the students. And this fateful day or week, norovirus struck. And so if anyone's had norovirus, I think you realize what that means. It's a sudden onset of vomiting and diarrhea, and stomach pains, and really incapacitating for those who are experiencing it. So on the second of the 3 days on site, the symptoms, students started getting sick. And within hours, a dozen or more students report the same symptoms. By the evening, over 1/3 of the students and chaperones were experiencing symptoms. The nurse contacted, as they should, the local public health department as it relates to a communicable disease outbreak, and received guidance from the local health authority. But the challenges as far as being at outdoor school, certain measures were difficult to implement. Parents were called, but what ended up happening is because of the limited facilities, students and staff and chaperones were unable to access bathrooms or other areas needed for their symptoms. In this case, the nurse, there's a lot of opportunities to kind of look at how this transpired, and the nurse spent time and showed off a shed full of PPE and other emergency kits that they have if this ever happens again, to try and mitigate, to help comfort with the students or the individuals having symptoms, as well as mitigate continued spread of the norovirus. So in this case, nurse on site, future planning is now in place. There's a whole, I wasn't going to say it, but there's a whole shed of Home Depot buckets with PPE, disinfectant, and a whole plan in place as it relates to contacting, isolation of students who are showing signs, those kind of things. Problem areas, and facilities and team were certainly caught unprepared for such a quick onset of a widespread illness. Increased speed due to lack of adequate hygiene and containment measures. And so the inability to contain or isolate, lack of hygiene, lack of running water, those kind of things all played a part in this challenging episode. So I don't think there's anyone here running an outdoor school program, but maybe on a field trip, and this could happen on a choir trip out of state, those kind of things. What is a proactive planning change that perhaps could have improved the future outcomes in this situation? Or 2, imagine an outbreak situation occurs and there's a student who has decreased immune function. or other experiences another disability or medical condition that puts them at higher risk, what is the plan or protocol potentially for that student safety?
I'm going to mention again, we welcome you to put things in the chat if that's more comfortable as well. And given how very talkative people have been, I'm going to go ahead and jump in at this point. This is really trying to point towards the idea of targeted universalism in this case, where there's an outbreak, we have a student with decreased immune function or higher risk. Maybe we don't even know that. That's something that maybe people have or have not disclosed. So whatever planning we put into place that's going to decrease spread, that's going to help contain, for example, I visited a school recently where the quote unquote health room, if someone was sick, was a set of chairs by the front entrance, sort of outside the main office, where kids could wait for their parents, holding a little trash can if they needed it. But they're in a hallway and classes, moving from class to class or walking right past them. So that versus having a designated space that has at least some amount of isolation so that if somebody is sick, regardless of what the symptoms are, if someone's experiencing potentially communicable illness, automatically they can go to a separate space. And that's actually written into law in our health services rule that there is some way to isolate. And that's a huge part of containing an outbreak, particularly if something as communicable as norovirus. And that as a universal measure is going to protect all students and those students that have decreased immune function or their special needs. And in addition to that, we can look at our individualized planning for those students. I know many of us have experience dealing with communicable disease outbreaks in the last 5 years or so. And all of the different types of mitigation that we needed to do, different modifications, if it is standard protocol, if someone's experiencing symptoms of illness, to wear a mask until they're picked up. If there are students that can't because of neurodivergence or because of physical, we had students that don't have an ear or don't have a nose in some districts that were navigating other ways to deal with that. So thinking about the universal measures and those individualized planning measures at the same time.
The other piece, the outdoor school example is a bit of, I think part of it is an extreme case, but shows the importance of, I think a lot of this planning has already happened throughout the COVID pandemic, and now as part of the prevention or health services plan, where a communicable disease plan is required. But the communication aspects of it, as far as who's communicating to who during an outbreak. In this case, local public health was contacted, being clear as far as whose responsibility that is, and that there's an understanding that what that means to work with the public health department. We've had staff members who have where reaching out to the public health department has been criticized as a maybe not appropriate step. There's times when it's required, and there's times when it's helpful, but just ensuring that everyone's on the same page as it relates to how the school district would address a communicable disease outbreak, widespread outbreak, but also even maybe school by school, building by building, class by class, how things are mitigated.
Right. More breath. Before we start this scenario, I just want to mention it is talking about lockdown, and it is based on a true story with some changes to make it anonymous. And before I start it all ended well. It was the best possible outcome, just because I know how activating this type of thing can be. I do think it's important to talk about, and as we're saying, even for drills of this type, to be ready to anticipate what we're going to need to do to have in place. So in this scenario, we're talking about a high school that has a protocol for hold and protocol for lockdown. They've been conducting the drills. for each of those protocols twice a year in addition to their monthly fire drills. The school has a resource officer on campus, and they have a close relationship with their local emergency response and police. And in this situation, a student reported to staff that someone was planning to come to campus. It was another young person, but not someone who was enrolled, and that student was seen shortly after on school property. And the communication had included that there was some negative intent of this individual. The school initiated a hold initially. All students and staff remain in rooms out of hallways. The non-enrolled student had been seen on campus, entered, local police were called, arrived on scene within minutes, and the non-enrolled student was, what's the word? Was caught, was stopped. During the event, from start to finish, the student body remained on hold for approximately an hour. And the school during that time was providing updates to students and families via text or email, whichever had been set up. After the event, the school offered additional support for anyone who felt they needed it, including access to the school counselors. And the following day, the school had a post-event briefing with staff, which some of the students then received additional information directly from their teachers. And in this case, this was about as perfect an example of a response to intruder as we could have. The staff were aware. There was real-time communication. The existing relationships meant there was a very rapid response, and essentially nothing happened. It was a potentially worst-case scenario, and it was resolved very quickly. Even so, with any sort of event like this, we have individual students who are expressing fear and refusing to attend. In specific cases, there may have been students who have other issues they're dealing with, either existing anxiety, existing health conditions that they're afraid that are going to be further impacted by those types of events. In one case, a student was expressing pretty significant anxiety and dysregulation, a student who has some neurodivergent aspects, but says, I don't even know my counselor. So a student who wasn't feeling comfortable reaching out to the available resources, and some increased absenteeism overall. There are questions on this. Is there something that we could have done to improve future outcomes? And thinking about those students that do have specialized needs, what if during that 50 minutes to an hour, one of our students with type 1 diabetes had a blood sugar that started dropping? What do we have in place to ensure that that student can remain safe even when they're on hold or lockdown? And I would love it if anyone has any sort of similar experience, if you've talked about this for your drills.
When Brenna and I were working on this presentation, that same 6-year-old of mine, kindergarten, she's talked about how they have the drills and it's presented to her very, that it's kind of a fun, quiet game. And it made me think, type 1 diabetes, or a situation where anxiety or stress may exacerbate a condition of asthma, or something of that such that would significantly increase the likelihood of a lot of noise in that classroom, which is the opposite of what we want to happen during that time. And so just not only the safety and the response to that student having a medical emergency during a situation like this, but also the risk that it poses to the environment around. They're competing, there's some competing forces there as far as how to respond. And I see Mitch is the expert.
Well, no, you kind of stole my thunder there, Eli. I was going to talk about the great use of dum-dum lollipops and the multi-use of those, and having students not only who have diabetes have access to those high sugar lollipops, but my kids are very young in elementary, and when they go through their lockdown drills, they're excited because they got to suck on a lollipop for the 5 minutes that it took. And in hindsight, with that for the teacher, it keeps them quiet. It gives them something to do keeps them focused on, okay, I get to have this lollipop. This is now a reward-based system on this, but making sure that whatever means that people have within their classrooms definitely do focus on that keeping quiet aspect, but also the health aspect with that, and having some waters, having some sugary drinks, having some lollipops or dum-dums with that is really going to be beneficial on a lot of different levels, not just for the type 1 diabetic.
Yeah. So again, that targeted universalism idea that this is going to protect our students with specific needs. And guess what? It can turn it around for other students as well. And that, maybe it's not specifically the lollipops, but thinking ahead to what is the community, what is appropriate for this particular community? What can we do so that it turns this from an unknown, entirely anxious and fear situation to something where it's a group support and some level of positive in whatever way we can. This particular example, we were also wanting to bring up the idea of post-event. So thinking about, you've got all sorts of planning in place to hopefully prevent things from happening. And then if an event does happen, to be able to respond in the moment. But after the event, whether it's a kid collapsing in front of their peers or a fire or whatever it is, any sort of urgent emergent situation is very likely to bring up emotional and psychological responses for people. So the planning ahead for that piece, having those rapid response teams or crisis intervention teams is certainly beneficial, and I think is part of the planning in a lot of places, but also the idea of relationship building, that if we have resources, if we have people that we're expecting students to be able to talk to and feel comfortable working with, maybe they can visit classrooms ahead of time. Maybe I know in one of the elementary schools we worked with, the school counselor did group connections, once a month or so with classrooms, so that the kids were familiar with this person's face and felt like they knew them. So that's sort of thinking ahead as part of planning as well, because ultimately, the ultimate universal goal for all of this, maybe we could say, is attendance or academic success and student safety, both. So thinking, we don't just want to keep kids alive. We want to make sure that they feel safe and welcomed and that they can thrive. So layered levels of planning to make sure that we reach our ultimate goals.
So the one thing that I would like to mention is, just having those drills set in stone allows those kids that are maybe a little bit more higher need to be seen and not lost in the shuffle. And so I think that's a strong point in support of, just continually drilling and making sure those feel comfortable and normal for everyone involved, and thus allowing like a little bit of mental space to look out for the folks that may not be doing as great.
But what kind of stuck out for me, one of the things on this example also is the communication that the schools seem to be doing during the event to keep the community and those that they could reach out to as in the know as much as they could. And it made me think, as far as if there was a medical emergency in one of the classrooms that was on hold, like how would the communication, is there a mechanism, or has it been planned as it relates to medical emergency of a student who's known already to be in that classroom? How would information get out during a crisis situation? So a planning point there, as far as we have a student who's experiencing low blood pressure, needs to be in an ambulance now. How would that go through during a larger emergency? I don't have an answer to that. Other than that, it seems to be like a good intersection as far as planning with that individualized health plan or PEEP we talked about before, as far as what tools are available during an emergency for us to communicate with other staff or to access emergency services.
And Bianca, I really appreciate your point that if we are doing, as I was talking about, if there are plans in place, if we haven't rehearsed that, it's sometimes a lot harder to actually make them happen. When the emergency happens, people tend to get a little bit flustered when they're faced with an emergency. We had an example of a student who had a specific type of emergency medication that was supposed to be administered by a certain route. And they had a second medication. They carried both of their medications with them. And in the event of an emergency, someone grabbed the wrong med. And they had been trained, they had, they knew how to give by the various routes, but they had just, it's easy to get flustered. So the more we can practice in a situation like everyone's been describing, where it's not as high stress as a real emergency, where it's set up as we've got this planned in advance. For those students that have anxiety and things, we've often heard that they're notified ahead of time, or there's some sort of, this is going to happen, so that it starts becoming familiar. Because the best laid plans aren't going to go anywhere if people aren't familiar with them and aren't able to enact them, even when they're faced with stress.
Well, it's happy to have more conversation or discussion. Corinna and my information are, and we're more than happy to set up a time to chat individually with folks, or come back, Alex and team, if there's questions. It's a really important nexus, and I think there's those districts who have access to nursing or other medically licensed staff. It's a great resource in this work, as we try to make sure every student is accounted for or planned for during emergencies. Please don't hesitate to reach out.
Well, yeah, thank you both. I think a couple of things that stuck with me is your discussion of targeted universalism. I mean, how many times you have somebody in your environment, whether it's school or otherwise, has some kind of medical disability or otherwise that maybe you don't even see, but if it comes to the fore during an emergency, it's important to know ways to address those for everybody's safety. But talking about the counseling after an event like this too, that's something we would like to follow up with regards to psychological first aid or something similar to that in a school environment post disaster, or even an event like this, to give folks some information. But thank you both. I think this is absolutely incredibly crucial information to consider for schools and emergency planning, making sure that those medical emergencies are addressed. With that, I'll stop recording here, and we'll pause if anybody has any comments or concerns or questions additional to this or otherwise. Please feel free to bring them up.